Same deal, the 5 times.
Okay. What do I do now?
You're live.
I'm live already?
Uh-huh.
I don't see me. There I am. Hi, I'm live, and this is Fishman, and welcome to our YouTube case review conference. And a couple of you may have dropped off because we're running a little late because we had problems getting this to work. But we're getting better at it, and one of the things we wanted to do was YouTube, and so we're putting a lot of new stuff on YouTube. So hopefully you'll see it there. Okay, so let's look at some cases. Okay, here's a good example. This is an incidental finding, and what do you see? You see evidence of calcification and low density around the right adrenal gland, and here it is a few more images. Now, when you have calcification of the adrenal, particularly around the periphery, you got to be thinking about old hematoma. Now, I've seen cyst calcify, but most commonly it's old hemorrhage. Things that can calcify include infection, but then usually you maintain the adrenal shape, like with TB or histoplasmosis. So the best diagnosis here would be an old adrenal hematoma. And again, when we look at calcifications, rim-like, thick or thin, is it punctate? Punctate could be myelolipoma. Dystrophic, you're thinking about adrenal carcinoma or pheochromocytoma. And then I mentioned the entire gland calcified, particularly if the gland is small, then you're thinking about TB or histoplasmosis. And then I gave you another case, incidental finding, which looks very much like the first case I showed you. Dense calcification, the lesion is low density, there's no enhancing, and that also is an adrenal hematoma. Now, just to make the point that not every adrenal calcified lesion is an old hematoma, what about this patient with left upper quadrant pain? Yes, you can argue, is this a spleen or a pseudocyst or something else, but when you look at the coronal views, you recognize it looks like a globe sitting on top of the left kidney. And what this was, I thought it was an old hematoma, to be quite frank. It was resected because the patient was symptomatic, and at the end of this day, it was a very unusual case. It was an adrenal mass, was an endothelial cyst. Endothelial cysts are not rare, but they're not common, but I've never seen one with dense calcification. So a great study. Now, what else can I show you? A patient with acute abdomen. Look at the patient's colon. There looks like a pancreatic. Here it is on the axial and coronal. Both the right and left colon, as well as sigmoid and rectum, are involved. Here's a few more images showing you the full extent of involvement. And here's the appearance on the cinematic. Pancreatic, you can think about ischemia, you can think about infection, you can think about a phone call coming through even, but I'll let that go for later. It shows we're live, right? I got a phone call. But also pseudomembranous colitis. Pseudomembranous colitis is one of the things that can give you a pancreatic with a really thickened colon. It gives you almost the most thickened colon, average wall thickness 11 millimeters, and ascites is common. And this was a great case of C. diff colitis in a patient who had a prior Whipple's procedure. Now, you can have a lot of reasons for C. diff colitis. Often patients had recent antibiotic therapy, but it's also important to think about this in patients who've had surgery and are being treated for, like this patient was getting chemotherapy for pancreatic cancer, was post-Whipple's procedure. Those patients often have all sorts of issues, and C. diff colitis is not uncommon. Of course, when you have someone with a Whipple's procedure and you see thickening here around the celiac and SMA and SMV, you also would always want to think about ischemia. Sometimes they look very, very similar. Another patient, here's an incidental finding. Is it near the pancreas? Now, if it's near the pancreas but not from the pancreas, I think about a mesenteric cyst, I think about a lymphangioma. When you look more carefully, and I'll take a few images, maybe the coronals are best, you see how it really comes off the patient's adrenal gland? The patient's pancreatic gland, their stomach, there's pancreas. When you think about a cystic lesion coming off the pancreas, you got to think about a lymphoepithelial cyst. They're benign lesions, and if you know it's lymphoepithelial cyst, they'll leave alone. Often the fluid is of low CT attenuation, even with negative attenuation. Here it is nicely, again, a few more images. Again, if this was near the pancreas, lymphangioma, mesenteric cyst, coming off the pancreas, then my diagnosis, which this was a lymphoepithelial cyst. A great case. Okay, let's keep going. I promised you more, and we got 13 of you out there. Left upper quadrant pain, and I'll tell you it's a 20-ish-year-old female. Large mass off the tail of the pancreas. What could this be? It doesn't look like a serous cystadenoma, but it's low density. It doesn't look like a carcinoma. It doesn't look like lymphoma. You can go and start thinking about things like MCNs or things like that, but usually they're more cystic. What is a large mass, low attenuation, but a patient's in their 20s and they're female? You kind of know what I'm going for right now. I'm going for SPEN, solid papillary epithelial neoplasm. They can be very large, can commonly occur in the tail of the pancreas. Resected is better than 90% cure rate. And again, we're seeing a lot of them. Usually it's defined to be in teens and young females, but you can see them in older women as well. So it's not just going to be for young people. Okay, another example, abdominal pain, and there's a pancreatic mass. The mass is cystic, but this thick wall is not a lymphoepithelial cyst, obviously. It's not a serous cystadenoma because the walls are too thick. If this is an IPMN, then it has malignant transformation. If this is an MCN, then I'm thinking about high-grade dysplasia. It doesn't look like a serous cystadenoma. Well, what could this be? You can see some of the cystic spaces disappear as you go from arterial to venous. There it is nicely showing arterial and venous together. And here it is with increased uptake on a PET scan. This was a neuroendocrine tumor. Neuroendocrine tumors can be cystic. We're used to seeing a one cystic lesion with rim enhancement. It's rare to see complex cystic lesions, solid and cystic and enhancement, but just a beautiful example of a pancreatic neuroendocrine tumor. Okay, let me just change directions a little bit. Hemoptysis, collapse left upper lung, thickening of the left mainstem bronchus. Could it be cancer? I guess you could think about that, but what's going on? There's infiltration about the left mainstem bronchus. There's collapse of the left upper lobe. What does that? Here's another coronal view. Yes, I agree, it could be a cancer here, but that wouldn't explain the infiltration around the left mainstem bronchus up to the bifurcation. Here it is beautifully with a virtual bronchoscopy, and then there's a little ulceration or outpouching at the area of narrowing in the mid-left mainstem bronchus. And when you see narrowing of the airway, when you see occlusion, yes, you think about tumor, but you have to think about things like vasculitis or other unusual conditions. And Wegener's one of the classic diseases that gives you narrowing of the airway. Wegener's is an interesting disease. It's a necrotizing vasculitis involving small and medium vessels. Presentation ranges from sinusitis to cough, fever, wheezing, and hematuria. You can imagine what this patient's symptoms were. And the lung is not an uncommon area. With Wegener's, upper airway involved in up to 92% of cases, like this case. Younger patients, male, male and female about equal, but females having airway problems are more common. And again, treatment with high-dose steroids typically. Wegener's, which has been renamed, but we won't go through that, can present many ways. Cavitary nodules, like in this case, large airway stenosis, large nodules, consolidation with or without hemorrhage, subglottic stenosis. Adenopathy is very uncommon in patients with Wegener's. So that's something to think about. Now what about this case? Cough and hemoptysis. There's something right at the tracheal bifurcation. What the heck is that? Well, could it be a polypoid lesion? Well, if it was, it's easier to see on a coronal view, and there, right at the tracheal bifurcation, there's a polypoid mass. You could say, well, could this be a foreign body? It's soft tissue density. It's attached. It doesn't look like a foreign body, but that would be a good thought. People aspirate all sorts of things. Here it is on the virtual bronchoscopy, polypoid lesion at the bifurcation. Here it is with another view. And here it is with an endoluminal view. Beautiful example showing a polypoid lesion. And if you look hard, this image shows that there are multiple polypoid lesions. So now you say, what gives me multiple polypoid lesions in the trachea and can extend down the airways? And one of the things to think about is tracheal papillomatosis. Patients can have multiple lesions. Here's another example where there are multiple polypoid lesions in the left main stem bronchus and in the trachea proper. So a very unusual condition, but something that can present with hemoptysis, more common in younger patients. Okay, let's keep going. What about this case? Rule out dissection, which means it's not a dissection when I say it that way, but look at the patient's left subclavian artery and left carotid. Look how narrowed the vessels are. But not only are they narrowed, but there's soft tissue thickening around the vessel. What does that mean? There it is on the carotids. There it is on the descending aorta. What are we thinking of here? Here it is on the thoracic aorta, and here is a 3D showing you the patient's left carotid, really narrowed, and left subclavian, really narrowed. So what am I thinking about? I'm thinking about a disease that causes narrowing of the vessels. That's a vasculitis typically. If you think about the left subclavian, the first thing you say is what's the most common disease to give you left subclavian involvement, and that's going to be Takayashu's aortitis. And this was a great example of Takayashu's aortitis involving the carotids as well as the left subclavian as well as the aorta proper. So medium to large vessels. Takayashu's is typically considered under the category of large vessel vasculitis, also known as aortic arch syndrome or pulseless disease. Is characterized by a panauritis affecting all three arterial layers and subsequent scarring of the media, which leads to luminal narrowing, as you very nicely saw in this case. Again, it occurs worldwide, more common in Asia. Again, a very important disease, a very overlooked disease. As radiologists, when we see thickening of vessels and it's not plaque, you got to be thinking about vasculitis. And for big vessel disease, you got to think about Takayashu's. So again, aortic involvement is common in Takayashu's, common in thoracic aorta, and especially left subclavian artery. It can also involve pulmonary arteries as well as the coronaries. So again, very, very important disease. So let me end this series with one last case. Back pain, look for bleed. I'm going to ask you, what is this? These little dots here. And look at these lucencies in the iliac bones bilaterally. And there is a big hematoma here, and there's some hematoma here as well. What happened in this patient? Here's some cinematic rendering views. Are you going to say this is metastatic disease? We got myeloma? Okay, maybe you think about that. But look how many little lucencies there are in a fairly organized pattern, but the rest of the bones look pretty good. Here it is with muscle, with hematoma, with the vessels, with these lucencies. What am I dealing with? Well, this is just a wonderful example of a patient who had a bone marrow harvest. You can see the multiple little needles that are put in to harvest the marrow. Beautiful, beautiful example. They can get complications like hemorrhage. Here's a really nice example. We published a similar case in Radiology a couple years ago. If you've never seen it, you start thinking about infection, you think about tuber. This is harvesting, beautifully shown on the cinematic rendering, nicely shown here again. So with that, I've shown you more than a dozen cases. I hope you enjoyed them. Those of you who are live, great to see you, or think I see you. A couple of comments from Tai Young Kim. Thank you always. Okay, appreciate that. But let us know. We'd like to keep doing this on YouTube. We do it on Facebook. Let us know what you think. We are pushing lots of new information on YouTube. So I hope you enjoy it. And with that, all I could say is see you the next time. And with that, Lily has pointed that I need to press the button here. So I will press the button that says end stream, and have a great day, everybody. Still going.
Great.